discussing this on and on and on, but today we're actually going to talk about muscles, actual muscles. So we are in chapter 2 of our trail guide book. We are talking about the shoulder girdle complex. The shoulder girdle complex, which is made up of 3 bones. Mr. Snell, can you tell me what 3 bones make up the shoulder girdle complex? Sir?
Hello? Can you hear me?
Yeah, I can hear you. Mr. Snell, what 3 bones make up the shoulder girdle complex?
The clavicle,
Yes.
the scapula,
Yes.
and humerus, I believe.
Sir, you believe correctly. That was fantastic. I called you out of the blue, and you were able to pull that up. I'd be like, what? Great. Thank you, sir. Thank you. Cool.
Thank you.
Hey, Miss Green, can you tell me what 3 bones make up the shoulder girdle complex? Miss Green? Dear Miss Green? Miss Green? Going once? Going twice? Mr. Jones, please.
I think it's the sternoclavicular? Or is this the joints?
That is the joints.
Dang it.
What,
Second.
sir, just wait, don't go anywhere. What 3 bones, what 3 bones make up those, the shoulder girdle complex?
Scapula,
Yep.
clavicle, and humerus?
Yes, sir. Thank you.
All
But
right.
sir, since you're in that vein of thinking, what 4 joints make up the shoulder girdle complex?
The sternoclavicular, the glenohumeral, acromial clavicular, and scapulothoracic.
That was beautiful. Thank you, sir. Thank you. Yeah, I love it. Mr. Manzanares?
Yes.
Sir, what 3 bones make up the shoulder girdle complex?
The scapula, the humerus, and the clavicle.
Yep, scapular humerus. Yes, excellent. Thank you, sir. Thank you.
No.
Cool. Mr. Overman, can you tell me what movements, I'm talking about flexion, extension, abduction, all that kind of stuff. What movements occur at the glenohumeral joint?
So you got flexion, extension, abduction, adduction, so it goes all the way around, circumduction, then you got horizontal flexion.
No, horizontal adduction.
Oh, yeah, okay. Adduction, horizontal, abduction. Get everything?
Only 2 left.
The rotations, and then medial rotation and lateral rotation.
Sir, well done, sir. Thank you. That was perfect, man. Darn. Cool. Miss Abelos, can you tell me the movements that the scapulothoracic joint can make? Like, what can the scapula do?
It can elevate and depress, retract, protract, internal rotate, elevate.
Well, yeah, it can elevate and depress. I'm sorry. It can upwardly rotate or downwardly
Or
rotate.
downward rotate.
Cool.
Okay.
That was good. What's the other words for protract and retract?
And
Beautiful. Thank you. Miss Green, are you there?
yeah, I'm here. Sorry.
Miss Green, well, you can help review. Miss Green, what are the 3 bones that make up the shoulder girdle complex? mic to him here. Can you see me, Miss Green?
Yeah.
So, got your collarbone, but we don't call it your collarbone. What do we call it?
I'm sorry. I'm like not here right now.
Okay, that's okay, but I need you here, okay? So, I'm going to call on somebody else. Listen up, because I'm going to call back on you again. Mr. Ma, what are the 3 bones that make up the shoulder girdle complex?
Clavicle, humerus, and scapula.
Clavicle, humerus, and scapula. Thank you, Mr. Ma. Yeah,
Thank you.
cool. Miss Green, what are the 3 bones that make up the shoulder girdle complex?
The glenohumeral and
No, that's a joint. And you're right, it makes up the complex. But what are the 3 bones? All right, hold on. Miss Green, I think it might help. Listen to what I tend to, just everybody should know this. I tend to ask the same question to people like multiple times. So oftentimes before I call on you, I've already asked somebody that question. So instead of looking at your book, you may actually want to listen to them because they'll tell you the answer.
okay.
It'll make your life easier.
Cooking, so I'm trying not to burn it, and I'm listening to, so that's why I was like,
I got that. Okay, hang in there. Hang in there. Miss Young. Hi, Miss Young. Miss Young, what are the 3 bones that make up the shoulder girdle complex?
The clavicle, the scapula, and the humerus.
The clavicle, the scapula, and the humerus. Thank you, Miss Young.
You're welcome.
Miss Green, what are the 3 bones that make up the shoulder girdle complex?
the clavicle, the humerus, and the scapula.
Thank you, ma'am. All right, everybody. So let's talk about how we move some of these bones, okay? And we're going to talk about 4 muscles today. I'll present pictures and all that kind of stuff here in a second from your trail guide. But before we get there, we're going to do the latissimus dorsi today, the teres major, the trapezius, and the deltoid. And we're picking these 4 muscles, I mean, obviously because they move your shoulders and arms. They belong in this chapter. But we're talking about these specifically because of how they work together. So, we are going to find that the latissimus dorsi and the teres major, even though they're very different size and all that kind of stuff, do the exact same stuff. And we think that they always work together. And so when I say they do the exact same stuff, they tend to both, and don't worry, we're going to go over them with pictures and everything, but they tend to both extend the glenohumeral joint, they both adduct the glenohumeral joint, they both medially rotate the glenohumeral joint. And so you're going to hear me say this for the next 9 months. Anytime I say latissimus dorsi, you should say teres major. Anytime I say teres major, you should say latissimus dorsi. And I don't mean that you answer me that way. What I mean is if an answer can be answered by saying, like, what muscle causes this? And the answer is latissimus dorsi, then the answer is going to also be teres major. They work together. They can't not work together, we think. I guess they probably could in some world, but the fact is it's a viable answer. If the answer is teres major, the answer is also latissimus dorsi. That's what I mean by any time I say latissimus dorsi, you say teres major. I want you to partner those 2 muscles together in your mind forever. Latissimus dorsi and teres major. Very different size, but they're all together. So anytime I say latissimus dorsi, you say teres major. Anytime I say teres major, you say latissimus dorsi. Right? Cool. Mr. Thornton.
Yes.
Mr. Thornton, anytime I say latissimus dorsi, you say what?
Teres major.
Thank you, sir. Miss Pugh.
Hello.
Hi, Miss Pugh. Anytime I say teres major, you say...
Latissimus dorsi.
Thank you. Mr. Bose. Anytime I say latissimus dorsi, you say... Thank you, ma'am. Miss Green, anytime I say teres major, you say...
Latissimus dorsi.
Yay! All right. So we partner those together. These other two muscles are the trapezius and the deltoid. They do not partner together like that. The trapezius can operate separately from the deltoid, but in a lot of movements they work together. And the thing that connects the trapezius and the deltoid, the thing that connects the trapezius and the deltoid is they share an attachment. They share 3 attachments. My trapezius essentially comes down off my head and goes into the shoulder here. We're going to find out there's more to it than that. And the deltoid actually attaches to the same place it inserts. So the insertion of the trapezius is identical to the origin of the deltoid. Where the trapezius ends, the deltoid begins. And that's very, very important because we tend to use this shoulder-girdle complex together. We tend to be moving the scapula, scapulothoracic joint and the glenohumeral joint and the sternoclavicular joint all at once, and that often involves the trapezius and the deltoid kind of working together. They're not interchangeable. There are many answers that are, the trapezius is the answer, deltoid is not. But they tend to flow together. They do share an origin and an insertion. So the insertion of the trapezius is the origin of the deltoid. They share an attachment site. And we'll see that in a minute. Okay? Let's, yes, Ms. Carrillo, please.
Never mind. Someone's helping her. There was a massage student that needs to be let in.
Oh, gotcha. Thank you. That door should be unlocked by now. Yeah. Miss Abelos.
So in the video last night on the latissimus dorsi, it said that the tres major and it share the attachment site on the lateral border. So when you see the muscles that share a border, are they always interacting with each other and performing similar functions, or no?
No. By the way, it's a very good guess. It's half right. The problem is they would have to share a border and go to the same place. And not all the muscles on the lateral border go to the same place. So that's why that logic doesn't work. But the logic is, you've got the right idea. Now, if they both shared an origin and insertion, then they would do the same thing probably.
Okay.
Yeah. But what you're really saying is they both share an origin, and that doesn't always mean that they're going to, it's kind of like Phoenix. That could be the origin, but you can go off to many different places from there. So, yeah. Cool. And by the way, very strangely enough, there is a teres minor, and it really has nothing to do with the teres major. They're in the same location on your body. That's why they got named that, but they do very different things. So teres major goes with latissimus dorsi. All right, let's share a little slideshow here. Please feel free to ask questions. You guys are very polite, and a lot of times you apologize for asking questions, but that's what we want. I want you here asking questions. Okay, shoulder girdle complex. We can actually see right here, this side of this gentleman's trapezius here. We can see it kind of weave down into where the deltoid starts. This is latissimus dorsi here, this huge muscle. And that's the teres major. Yeah, sorry, that's the teres major. I want to make sure it's telling you the right thing. That's the teres major right above it. All right, let's look at these one by one. By the way, teres major and teres minor are right by each other, but they go off to different locations. So that's why we're not going to include them together. They do very different things. And in this class, we actually we care about the names so we can talk about them, but we actually care about the actions. What do they do? How do they move my body? That kind of stuff. By the way, these pictures can be confusing to look at because what they've done is they're showing you a lower layer on the right side than they are on the left side. They've pulled the left side muscles off so you can see what's underneath them on the right side. So it's not symmetrical in that sense, and that can really throw you off. Oh, by the way, this latissimus dorsi here, do you see what it weaves down into? It weaves down into this big sheet-like tendon. What do we call sheet-like tendons? Sheet-like fascia. Yes, all day long. Aponeurosis, thank you. This is they say the thoracolumbar fascia, which is true, it's all fascia. but this is called the thoracolumbar aponeurosis. It is in your thoracic, lower thoracic region and lumbar region, the thoracolumbar region. And lots of muscles weave into this big sheet-like tendon. It's very thick, it's very strong, and that thing weaves down into your glutes, believe it or not. So this low back kind of thing, everything kind of comes together at the thoracolumbar aponeurosis. It's very important to understanding how backs work and why they tie into your hips and why your hips actually tie into your upper body. Mr. Craven, please.
Yeah, is there a reason why, like, it's all fascia right at that specific spot rather than just like them connecting to the bone instead?
Yeah, no, it's a great, great question. Do you have kids, sir? Mr. Craven?
Wrong button. I have a puppy.
Okay. All right, well, this actually kind of, well, no, it doesn't. Anybody who's played with kids, I was trying to give this great example, but here, if you've ever had a little kid and you want to make them kind of fly around the room a little bit, and you pick them up by their clothing, you want to pick them up, you don't pick them up just by their shirt because you'll hang them, right? You know, they're not puppies, they don't work that way. And a lot of times what I'll do is, like when I'm roughhousing with little kids, I kind of wad up their lower shirt behind them and their pants, and I pick them up from there. You kind of pick them up from their belt, so to speak. And it evenly kind of distributes their weight, and you can move them around. Well, if you think about it, you've got to tie your upper body to your lower body, and when it pulls, you don't want it to just pull on one tiny spot. You want it to distribute that pulling. If you're climbing up a mountain, you don't want all that pulling just to go to one spot. You want it to tie into the thing it's got to get up that mountain, and that's your butt. So I'm kind of half making a joke, but it's also true. It's got to get your butt up the mountain, and we've got to tie everything to that. And so it's a way of tying in the center mass of your body to everything else. So the thoracolumbar aponeurosis helps tie the upper body, the lower body, and distribute all these forces coming into it from all different angles. And that's why it's like that and not just like directly to the bone. It helps distribute all those forces, and they're massive forces.
Would you say that, like, it's kind of not like, it's not like the brain center, but it's kind of like the nucleus of the body almost?
I would yeah, some people would call it your center of gravity. And it's definitely a central weaving point for all sorts of stuff to come together. Absolutely. Yeah. I like the way you put it. Yes, sir. I would. Yeah. Mr. Singletary.
A question about the muscles. Like on the chart where it has the latissimus dorsi, if you look on the opposite side, is it sitting actually on top of these other muscles?
Yes.
That's why it's in the picture. Okay.
Yeah, so if you look at where it says thoracolumbar fascia cut and reflected, they really are like if a surgeon went in there and cut the latissimus dorsi off, removed it, and pulled this fascia back, here's what you'd see underneath.
Okay.
Yep. And if you removed half the trapezius on this right side, here's the stuff you'd see underneath. So on this right side, they've removed latissimus dorsi, they've removed the trapezius, and they've removed the deltoid.
Okay, I see.
Yep.
Okay.
And this is
why that's why I was having trouble with some of the other charts in the book, because I'm like, okay, it's on one side, but I can't see it on the other side, and I can't tell which muscle is underneath the other muscle just by looking at one. Okay, I got you now.
Yeah, and this is actually what's a little bit tricky for massage therapists, especially in the beginning, is we're not just dealing with like knowing I-17 goes from Phoenix to Flagstaff. We're also dealing with what is underneath I-17. What cable lines are running under there and all that kind of stuff. So and that's why we use words like superior and deep, because there are layers and layers and layers. And in your back, I mean, there's about 5 layers of muscle. So we will get into all those though. But yes, yeah. Mr. Craven, you still have your hand raised. Did you have more, sir?
I'm still figuring out the buttons, but I guess I do have more.
Please, please.
Yeah, on my phone, so it's a little weird. So like when like the latissimus dorsi turns in and connects with the hold on. It's really tiny.
With the
thoracolumbar fascia. does the muscle go under that, connect to something else, or does it directly connect and like close itself off when it touches the fascia? Like it turns kind of into that tissue.
Yeah, it's true. It definitely doesn't go underneath it. It's true to say it turns into. There are two ways to think about this, and they get really tricky. But one thing is, don't think about the body as having like beginnings and endings to stuff. Think of it like a knitted sweater. So the latissimus dorsi is literally knitted into the thoracolumbar aponeuroses. That's a more accurate way to look at it. But it definitely is becoming that, so to speak. Yes. That is a big tendon for it. Yes. And
it's like a really interesting Christmas sweater, kind of, in a weird, like, body type sort of way.
Actually, this is a really good question you've asked, sir. I'm going to stop sharing for just a second so you guys can see the whiteboard behind me. Just something for you to think about, everybody. This is a hard concept to get, just visually, but it's really important. So, here's a typical muscle, right? Typical muscle, it's made up of all these fibers running through it. Millions, by the way, millions and millions of fibers, not 3. Okay? What is around every single muscular fiber? Fascia is around every single muscular fiber. So the red muscle, the stuff you guys eat, steak, the red muscle is surrounded by fascia, including the steak you eat, by the way. It's part of the reason it's firm. It's the main reason it's firm. Is surrounded by fascia, and then remember, groups of those are surrounded by fascia, and groups of those are surrounded by fascia, right? And so, in Anatomy 101, we tell you stuff like, we say, hey, what connects muscle to bone?
Tendon.
Yes.
Tendon.
There we go. So this is the tendon, right here at the end. And this is that white stuff that, like, when you guys have been doing, like, preparing chicken, sometimes there's like this white piece at the end, and it's really hard and rubbery. And if you put it in you never put it in your mouth, but if you did, you'd have a hard time even chewing it up. It's really solid. That's tendon. So when we first teach you anatomy, just like everything in life, by the way, everything in life we oversimplify and then build concepts on top of that. When we first teach you anatomy, we say, hey, tendons attach muscle to bone. And that's true because we see them at the end of muscle and they go to bone. That's true. But really, it's not like there's this section of tendon that we put on the end of the muscle to attach it to the bone, and that's kind of the way the books explain it. And that's not really true. Remember, there was fascia over all the muscle, right, wrapped around it? The tendon is just a spot where there's still all of that fascia, but no muscle. So have you ever tried to pull your socks off at night from your feet, and you pull from the toe and they won't come off really, and you just got this stretched out sock at the end? The sock is all over your leg. It's all over your leg, and the part you're holding is sock, and that's the tendon. It's just sock with no foot in it. This is a tendon. We don't call it that because when we fill a tendon with muscle, we call it muscle. But it's really, this is a big fascial sock, and this part's full of red meat, and when there's no red meat, you're just left with fascia, and we call that fascial intersection between the muscle and the bone, we call that tendon. And so when we say, like, when we look at the latissimus dorsi, and we say, well, where does it stop and where does the thoracolumbar aponeuroses end, begin? That's an impossible question to actually answer. Because what happens is the muscle just starts disappearing in this area and you enter the tendon zone, right? And it doesn't even happen all at once. It's kind of, jagged through here as muscle kind of runs away, and all you're left with is stringy tendon. And it's why these things are so strong and such. But remember when I was like, fascia's everywhere? It really is. And so this is all fascia. The bone's covered in fascia, right? But the bone is fascia filled with calcium and potassium. This is fascia filled with muscle, and this part in the middle doesn't have any muscle or calcium, potassium. It's just fascia, and just fascia is like tendons, ligaments, aponeuroses. And aponeuroses is just a big sheet like one of these. So when I say it weaves in, it would even be more accurate to say the thoracolumbar aponeurosis is an absence of latissimus dorsi and all these other muscles. It's really the fascia from those things all coming together into one big fascial meeting spot. I hope that helped. Yeah, it's fascinating. Okay. Mr. Craven, more? Just had your hand up, but I know you're on your phone.
My bad.
No, it's good. All right. Moving right along. All right. So let's go down here and look. And by the way, this should tell you something as a massage therapist. Most people get really cautious in the low back. This is not the area I get cautious. This is the area, I mean, I stay close to the spine. I don't want to go through some of these kidneys, which are over here. But this area is so thick with fascia that this should be the area of the back you can go the deepest on. You know, if it's done right, I'll show you guys some stuff. If it's done right, you can go crazy deep in this area. Crazy tapscott deep. That's deep. All right. Beautiful latissimus dorsi. Latissimus dorsi, the lateral back muscle, covers the back and the lateral side of your body. Latissimus dorsi. Latissimus dorsi is the largest muscle in the upper body. Largest muscle in the upper body. Boom. So large we can even see it from the front. Boom. Okay. Let's get rid of some stuff here. Sorry, guys. Wait, let's see one thing. No. All right. So let's talk about the deltoid more specifically, and then the trapezius, and the latissimus dorsi, and the teres major. The deltoid. The deltoid is made up of 3 sections. It is called the deltoid because it looks like a delta, which is an upside down triangle. It looks like a delta and it's upside down triangle. It has 3 sections, one in front, one in the middle, and one in the back. So front, middle, back. So we call the front fibers of the deltoid the anterior fibers, right? We call the fibers of the back deltoid the posterior fibers, and we call the ones in the middle fibers. Some people call them the lateral fibers, and that's fine by me too. They are most lateral out there. But they are also between the front and the back, so they're called the middle fibers. Anterior, middle, and posterior. And the reason we make this distinction is, do you remember I said muscles can only do one thing? Right?
Contract?
Yes, they can only contract and they can only shorten. They can only pull. And by the way, contract's the right answer, but they can only pull. And therefore, if you've got a deltoid in front and you've got deltoid fibers in back, those 2 fibers do very different things. Very, very, very different things. Yeah? So the ones in front can tend to pull you in front, and the ones in back can tend to pull you in back. I mean your arm, not you. Mr. Singletary, please.
Are they going to be antagonists to each other then, if that's the case?
Oh, beautiful, sir. Yes. So
Okay.
that's a great test question, by the way, because it is a muscle that can antagonize itself, right? It can fight with itself, kind of like we all can, right? Most of our arguments are with ourselves. So yes, the front fibers can be antagonists to the back fibers, the posterior fibers, and the posterior fibers can be antagonists to the anterior fibers. Absolutely. Yep. Cool. And I don't normally do this, especially because we're just right about in here, but I want to take our break right now because I want to run to the next room and get tape to kind of show you guys some stuff about the angles these fibers run, because it'll help you with kinesiology. So I apologize, but we're going to take our break a little bit early, if that's all right. And so we'll be back at, 9:35, 9:34, well, wait 1 second. Miss Abelos, please.
Are we allowed as massage therapists to apply kinesiology tape on our patients?
Yeah, I think so.
Oh.
Yeah, good. All right, 9:35, everybody. We'll be right back. I'm going to get some tape, kind of show you some stuff. Okay. Let's discuss kind of the concepts of kinesiology as it pertains to the deltoid. All right? I made a big statement at the beginning of this class, not today, but at the beginning of this program, that if you know origins and insertions, you don't have to memorize actions. And I stand by that. So I'd like to give you an example with the deltoid because it's a beautiful one to look at. It gives us a really good idea. We're looking at here. I'm going to turn my camera down a little bit so that we... There, good. Okay, here we go. So, I'm going to oversimplify things here, but they are 100% accurate. The anterior fibers of the deltoid and the posterior fibers of the deltoid and the middle fibers of the deltoid all insert into a bump on your humerus. All of them insert into a bump on your humerus, and that bump is conveniently called the deltoid tuberosity. So we now know the insertion for all three sections. Every last little fiber, they all kind of come down there. That is the tip of our upside down triangle. Well, the anterior fibers come from as far as the lateral 1/3 of the clavicle. What that means is if you take the collarbone, you divide it into thirds, and you take the lateral 1/3, it starts here. Most of us don't think about that. It probably starts even a little bit more in. It starts about here, and it goes down to here. Now, there's a whole bunch of fibers. The part I'm simplifying is I'm not going to tape off every single fiber. But then there are middle fibers that kind of come from the acromion process. Kind of come from the acromion process right here. I've made it too long. Hold on. My fibers are too long. Okay. Acromion process kind of off the side. These are the middle fibers. Still come down to this point right here. Yeah? And then this part people really don't realize, but the deltoid's attached to the spine of the scapula too. The spine of the scapula goes way over here. So I'll see if I can even reach this on myself. But they go way back over here. So let's take a very simple example. Let's look at just the middle fibers. If these fibers shorten, these fibers that attach my humerus to another bone, my scapula, they attach my humerus to my acromion process, which is my scapula. If these shorten, if these fibers shorten, what kind of action am I going to get out of them? Abduction of the glenohumeral joint. That's exactly what they do. They pull your shoulder, and if you pull on this, my arm comes out. You don't have to memorize that, because you have to memorize the origin insertions. You need them to be a good massage therapist. You need to know that when you're at the acromion process right below it, you're starting to get into the deltoid. And you need to know the deltoid ends down here because you got to massage it. But the action you can visualize. You can say, what happens if this shortens? My arm is going to come out, and that's called an abduction. Yeah? Okay. So, some of the more trickier stuff is when something runs diagonal. And the anterior fibers and the posterior fibers run diagonal. Means they don't run completely straight up and down. They don't run completely side to side. Yes, Mr. Singletary, please.
So the origins, the portion of the muscle that you were pointing to, that's the part that's not moving. Is that the understanding?
In general, not always, the origin does not move and the insertion comes to it. So in general, insertions are more distal and origins in general are more proximal because they're anchored in closer proximity here. So usually as I go out further, it's more likely to be an insertion. The stuff in closer, more proximal, tends to be an origin. I don't really care. The fact is, what really happens is, I don't mean that snotty, I just mean like, I don't care in the sense that what happens is, these 2 points actually come closer together. Believe it or not, by the way, sir, it'd be very hard for me to do, but we could keep my arm still and I could bend my shoulder in like this, and that would still be the same action. I'm still bringing these points closer together. So the point is, those 2 points, those attachments, one we happen to call an origin, one we happen to call insertion, but there are two attachments. They come closer together when the muscle contracts. Boom. And we would call this an abduction of the glenohumeral joint, and we would say really all the shoulder fibers are involved, but it's mainly the middle ones are involved because they pull out like this. Yeah. Was there another hand raised? No? Okay. Oh, Ms. Carrillo, please.
Well, that was me, but I was gonna ask, it's kind of like how when, it was before you said anchoring, so I'm like, oh, maybe if there's like a boat that had an anchor down in the sea.
That's exactly.
Like the boat isn't going anywhere, but like it's still floating around. It'd be floating away if it didn't have its origin, which is the anchor down there.
Yes.
Kind of like that.
It's very much like that, and the boat is the insertion. If anything is going to move, it's going to be the boat, right? Right. The problem is there are actually instances where the anchor moves and the boat doesn't. Not in that analogy, but anyway, that's why I try not to get too tied up on. I just think about it as all attachments. But yes, Ms. Carrillo, please.
When you said that, it made me think more like a yo-yo at that point, because the yo-yo string goes around like the finger, and the finger, although it is the anchor point, it can still move and everything. So I use that analogy for that part at that point.
That is actually a perfect analogy, because sometimes when you're yo-yoing, right, the yo-yo usually comes back and forth. The yo-yo usually comes to you. And that means it's an insertion. But people are really good with yo-yos. Sometimes you see them drop their hand down. They bring the origin to the yo-yo sometimes. And so that's exactly, and your body can do the same thing, right? I can do a pull up and a pull down, and they're the same action. But one, the origin's going to the insertion. The other one, the insertion's going to the origin. But a pull up and a pull down are the exact same action in the gym. But one, I'm bringing my origin up to that location. The other one, I'm bringing the insertion down to it in a more normal fashion. So anyway, okay, so that's the middle fibers. If we look at the front fibers, right, they can do several things because of this diagonalness. But, and by the way, no muscles act alone. So the reason we can get different movements out of the same muscle is other muscles we're going to learn about later kick in and help stop an unwanted movement. But if these anterior fibers pull, as most anterior fibers do, you will get this action. If they're in front and they pull to the front, one of the things you can get is a flexion. Thank you. You can get a flexion here. Yeah. Now, they also go diagonal, which means you could, because I'm kind of grabbing here diagonally, I can also get a rotation. What type of rotation is this? Oh. Medial rotation. So they can also help with a medial rotation. Also, if I'm way up here, horizontal, can we see that if these front fibers pull, you get a horizontal adduction. Yeah. Now, I honestly did not look at the book for that. I just looked over just now to make sure I was right. But that is exactly what your book just said. And that's not from memory. That's from me going, I put my fingers here. Let's see. Flexion, horizontal adduction, medial rotation. I can see that. I can see that. Yeah. And by the way, you can also see if you have these lines on both sides that they also will help with an abduction. They all help with that because they're all pulling on this area. So, Mr. Singletary pointed out that the anterior fibers can fight with the back fibers. That's true because look, these are going diagonal, so if they cause a rotation, they're going to cause me to do a lateral rotation. They're going to cause me, if they pull, they're going to cause me to do a extension, absolutely. And if I'm way over here doing a horizontal adduction, they can cause me to do a horizontal abduction because they're behind me pulling back. Now, I don't care if you get that 100%, but do you see the basic premises? Because that is the basic premises of kinesiology. That muscles can only do one thing, contract, which means shorten, and that the attachments, the origin insertions, when that happens, have to either come towards each other or the muscle has to tear. Something has to happen. They come towards each other, and the joint in the middle has to allow them to do whatever the joint in the middle does. This is a ball and socket, so it can do all sorts of crazy stuff, right? When it comes to my elbow, the only thing it can do is flex and extend. And so anything that attaches down here from anywhere tends to flex it. Anything in back tends to extend it. But the point is that is the whole basis of kinesiology, what we just did together as a team. And that's action. So on every kind of muscle, I'm literally, in my mind, just taking these two fingers here, like this, and shortening them. Seeing what happens when I shorten. And I can get the actions from that. And I can do it in my mind. This part's super stupid, but for some reason it really helps me. I even, on some parts of the body, imagine two little elves, I don't know why, and they've got a rope, and they're both pulling on it together, reeling each other in. And I'm like, if these elves get closer together, what's going to happen? Put an elf here, and put an elf up here, and have them short pull on a rope. And that's what's going to happen. So those elves have to get closer together. And by the way, I don't care if the insertion's coming to the origin, or the origin's coming to the insertion, my elbow bent the same. It's the same to the elbow. And that's what we're talking about right now. Just imagine them floating in space, all right? Cool. So, that is the deltoids. The deltoids have an insertion of the lateral 1/3 of the clavicle. And if I follow the lateral 1/3 of the clavicle over, what bone do I run into? I go across the acromioclavicular joint, and I get to the acromion process on the scapula, and the acromion process turns into the spine of the scapula. So these things in the book look really tricky because you look at the origin, it says lateral 1/3 of clavicle, acromion process. It doesn't say process, but it is acromion process and spine of scapula. And you're like, I gotta remember those three things? Like, I can't even do that. But I don't remember those three things. What I remember is deltoid. And if I kind of remember where it starts, if I kind of remember where it starts, I just trace that. Lateral 1/3 of the clavicle, acromion process, spine of scapula. That is, they're just describing a path to you. I-17, turn off at Sedona, take Highway 89A up to Flagstaff. It's just a roadmap. So if you know your bone anatomy well, and you know where to start and where to end, you're just describing this path in anatomical scientific terms. Please don't go through your book and just be like, lateral 1/3 of clavicle, acromion process, spine of scapula, and not know why you're saying that. That's great memorization, but it doesn't do you any good in class. I want you to know that, like, hey, when I'm rubbing here, all the way back here, this is the stuff that starts to make you a better massage therapist. Most people think deltoids are right here. Well, they are, but they don't realize they go all the way back to here. They're huge. They're really quite big. They think it's just this thing right now. Darn, hold on. They think it's just this, but it's going way back here, way in front. It's a very big muscle, okay? Now, the deltoid crosses over what joint? It's going from the scapula to the humerus, so it crosses over the glenohumeral joint. Thank you both. Yes, glenohumeral joint. That is the only joint it can move. It doesn't move the scapulothoracic joint. You can only move a joint you cross over, right? If I got a muscle from here to here, the only thing it can affect is my elbow all day long. If the muscle only goes from here to here, that's it. So don't get confused later because we're going to be dealing with muscles that move the scapula and muscles that move the glenohumeral joint, and those are very different things. So when I move my scapula, I'm taking my shoulder along for a ride. The glenohumeral joint's moving, I guess, but it's not moving, it's just being carried along. My fingers are being carried along too, but we don't say that they're moving. This muscle crosses over the glenohumeral joint, it moves the glenohumeral joint, it gives me abductions, horizontal adductions, horizontal abductions, medial rotations, lateral rotations, all happening here in the glenohumeral joint. Yes, it's anchored to the scapula, but it has nothing to do with the scapula. In the sense that it doesn't move the scapula, it moves the humerus. Miss Clayton, please.
With the glenohumeral joint, does gleno mean anything?
Yes, it means glenoid fossa. And in the scapula, the little teaspoon thing that's supposed to be the socket of this ball and socket, but it's not much of a socket, is called the glenoid fossa. Or glenoid cavity.
Right.
Yeah. And so
Right.
it fits in there, and that's where it's coming from. You're right. I wish it was called the scapulohumeral joint. That would be a much better name. But they call it the glenohumeral joint. So they're naming it by the fossa that's in the scapula, the glenoid fossa or the glenoid cavity, this little depression that the head of the humerus fits in.
Thank you.
Thank you. It's a very important question. All right. So in our mind, by the way, also, the deltoid might as well be 3 separate muscles. I mean, sometimes they work together, but sometimes they work completely apart. Usually when your anterior deltoid fibers are firing, your posterior ones aren't at all, and vice versa. Yeah. They all work together when you're doing an abduction because they're all pulling from all sides to kind of triangulate on here and get your arm up. But my point is they can operate 3 completely separate muscles. Yeah? Okay. Questions? If it doesn't make sense, please don't be afraid to be wrong. You cannot learn without making mistakes. And not only that, by the way, something just to think about, because you guys are about to become, you're doing something that's not just scientific, you're doing something that's artistic. You can't do anything original if you don't risk being wrong. So, I mean, this is a true deep life fact. If you don't risk being wrong, then you're really just repeating stuff I've said and other people have done. And that's okay, but you are a robot. I would much rather you make huge mistakes, say super stupid things as we discover incredibly amazing things too, right? So, and obviously they're not stupid things, but my point is, please don't be afraid to be kind of like, so if I stick my finger in my ear, will that help me raise? I don't know. Let's find out. Let's find out together. Somebody raised their hand and then I missed it. No, just my imagination. Okay, so I hope that you've all touched yourself during this talk, that you've actually touched your lateral 1/3 of your clavicle, you felt it turn into your acromion process, you felt it turn the spine of your scapula and go all the way to the medial border of your scapula. And you now have a fairly good idea of the deltoids and the deltoid actions and the origins and insertions and kind of get an idea for that. All right. It's a very easy muscle to palpate because the muscle is superficial. You can't get any more superficial than the deltoid unless you want to talk about the skin on top of the deltoid, which happens to be more superficial, but there is not another muscle on top of the deltoid. It is the most superficial muscle in this area. So it's immediately palpatable, which means you can touch it through the skin easily, the entire thing. Which leads us to the trapezius. A lot of people think about the trapezius as like, well, we used to have this guy on the football team, we called him No Neck Nick, because he had such a big trapezius, it looked like he didn't have a neck. And Nick was okay with this. But the trapezius is not just this area up here. The trapezius also has 3 sections, not all muscles do, by the way. It's got a superior fibers, middle fibers, and lower fibers to it. But they all insert in the same place that the deltoid started. So they insert on the lateral 1/3 of the clavicle, acromion process, and spine of the scapula. This is really interesting too. The origin, essentially, by the way, of the trapezius is a diamond. It's a trapezoid. It's a diamond. That's why it's called that. And essentially, its origin is the spinous processes, the bumps on the back of your spine, from like C2 to T12, which is your last thoracic vertebrae. It essentially comes from here and it triangulates too, very much like your deltoid. By the way, bodies are full of triangulation for very good reasons that we'll discover. Full of triangulation. So this thing comes here right? And let me stop sharing for a second to kind of make a point here. So, this guy very much has 3 sections also. Boom. Oh. Sorry. There we go. 3 sections also. Were this an actual trapezius, all this would be filled in. But now, most people think that's it for the trapezius, right? It's attached to the acromion process and the spine of the scapula. But I said it shares all the insertions, all the origins of the deltoid. So it also gets on to the front of the clavicle a little bit. Whoa, come on, buddy. Don't do this to me. Which is extremely interesting. So, here we go. So it's very hard to see in a video, but it's hooking onto the front of the body too a little bit, which means your trapezius comes down and wraps around a little bit. You can actually hook, people don't like it, but you can actually hook underneath the trapezius right here. You can kind of do it on yourself because it's rounding a corner. It actually folds in a little bit on itself. It should be really painful, by the way. You wouldn't do this to a client, but it's actually coming, it's rounding my corner, so it's not just a tent. It's a tent that actually goes around in front a little bit. Because the insertions of the trapezius are the origins of the deltoid. It's lateral 1/3 of the clavicle, which means it's all the way over here, which means it kind of wraps around here, comes in front, which means there is a little lip here that you can actually hook underneath of the trapezius. You probably wouldn't in massage because it's kind of painful, but the fact is it's there. This thing's massive. So, let's look at this really quickly and figure out actions. We don't need the book. We don't need no stinking book, right? Hold on, let me get this guy up here a little bit higher. There we go. All right. You've got these middle fibers running across. What happens if these shorten? There's 2 words for it. Anybody want to give me both words? What happens if this shortens?
Abduct.
Hold on 1 second, Mr. Singletary. Sorry, Miss Ablos, you said adduct.
Adduct and protract.
Retract.
Retract.
Yes. Adduct. It's going to actually, because the spine's not going to move, it's actually going to pull the scapula closer to the spine, right? And that is adduct. It's going to add it back to the spine. Or retract. So you see guys do this all the time. When we want to start a fight, use our middle, I don't know why we do this. We do our middle traps and hey, it looks like I'm pushing out my chest, but actually I'm not pushing out my chest. I'm pulling back my shoulders. I'm retracting them with my middle trapezius. That's what it does. It pulls back like this. Middle trapezius retracts or adducts. It adds my scapula in closer to my back. Cool. You didn't even have to look at the book for that. We've got fibers going kind of downward. Now they are going diagonal, but don't even worry about that. What are they going to do if these fibers down here, raise your hand, if you know what these fibers going down are going to do? Miss Everson, please.
Depress the scapula?
They will depress the scapula. They will pull it down, which we kind of think, well, gravity does that for me all the time. When do I need to do that? There's lots of times you need to do that. When you're pushing yourself up on something, your scapula has to come down. So I'm pushing up, but I'm pushing my scapula down to get up. So when you do dips at the gym, yes, dips are a pectoralis major muscle working thing and a triceps thing, but they also work your lower fibers, your trapezius. And by the way, because they go diagonal, as this goes down, what's the other thing it can do?
Medially adduct.
I like that. Adduct. It can adduct. It can adduct. That's beautiful. And adduction is going to the middle, so that's great. So it can depress and adduct here too. But the most important part is just it depresses, right? It pulls down. So if it depresses, What does the top ones do?
Extending. Oh, they elevate.
Thank you. They elevate. Well done. They elevate. They elevate. So kind of along the veins of Mr. Singletary talking about the deltoids fighting with themselves, can your trapezius fight with itself? Yes. If somebody is tight in the upper shoulders, is it possible they are tight in the lower back, in the lower trapezius fibers, because the body is trying to reinstill good posture? Your body knows you're not supposed to walk around like this. It knows that. It's very smart. And so what it tries to do is pull you back down like this. Think about this for a second. This is kind of fascinating. This is super fascinating in my opinion. Have you guys felt your own shoulders or somebody else's shoulders and they're like a rock? You felt their traps are like a rock, right? Well, they're like, why are they like a rock? They are contracting, right? That's what makes muscle hard. Touch your bicep right now, nice and soft. Flex it, nice and hard. When your muscles are hard because they're contracted. So if the trapezius is contracted and you feel somebody's shoulders and you're like, oh my gosh, those are like a table. They're like a rock, but their shoulders are looking like mine. Why are their shoulders not up in their ears if they're fully contracted? Please, Miss Hendrickson.
God, I can't reach my hand raising button. So because the lower fibers are trying to pull it down.
Because your body is trying to pull it back into good posture. And that's why it's tight, because it's doing what I do when I flex. If I'm just using my bicep, I just use it. If I'm trying to flex, I have my bicep fight my tricep so it puffs up here, right? Mm-hmm. If I had good arms, this would make sense. But you get the idea. This thing is flexed because it's fighting with some other fibers that are doing the opposite thing. Why is this so amazing? Why? Because
it's trying to like reach homeostasis. Okay.
Yes, it's trying to reach homeostasis. It also means that what makes many massage therapists better than somebody else who just does a back rub is they know to stop the argument, not just the symptom. Mm-hmm. So if Miss Hendrickson, if you and I are in a fight and they get me to calm down, but you're still being a pain in the neck, you're going to piss me off again. You're going to keep saying stuff to me, right? But if they calm us both down, the fight might be over. Right. So if you loosen up the upper shoulders, but the lower part of the traps are still pulling on them, eventually the upper shoulders tend to pull back again. You want to stop the fight. And so this is where we start to get into chains of action and no longer we're like, oh, hurts here, rub here, ugh. Hopefully you all knew that before you came to class. We all knew. We've all bumped ourselves into a wall and been like, ow, that hurts. You were all massage therapists at that level when you came here. Mm-hmm. We want to be a massage therapist, put chains of events together. That's why this is so amazing. Miss Everson, you had your hand up for a while, and then I didn't call on you.
Yeah, I noticed a lot of knots in that area with people, and is that basically because their upper portion and their medial portion are basically getting like tangled and trying to fight with one another?
Well, it'd be upper and lower, and but yes, the short answer is yes. Yeah. It's also.
So you'll just get bunched up, and that's where those big knots come from?
The knots are essentially the muscle stuck in a contraction. Yep. So that's where that hardness is coming from, if that's what you mean. Yeah. Yeah. And that's a very common thing we see. By the way, everybody, it doesn't mean it's always fighting with the lower trapezius fibers, but it's a really good culprit to look at. It's a really good culprit to look at.
So when you see those big knots and you're working on those knots, it's a good idea to do all of the insertions and the origins of the entire trapezius?
Yes. I mean, that's not a bad yes, that's not a bad idea too. Yes. But definitely working the muscles that do the opposite is not a bad idea, and that's the lower fibers. But you're right, just work the whole trapezius. I know a very good therapist who doesn't know their anatomy very well, but they actually are a really good therapist. And one of the things they do is they just make sure to branch out on everything they do. Right? They're like, I know it hurts here, but I'm going to branch out here because they're trying to look for those other connections. And that's what you're talking about, which is brilliant. Absolutely. Mr. Singletary, you had your hand raised, sir.
Ms. Eversole asked the same question. You answered it.
Oh, good. Okay, cool. All right. So anyway, let's go back to our little presentation here. And see if this doesn't all make sense. Now, again, origins and insertions are going to sound really tricky for this because they're going to have to describe this whole center line path as an origin. But essentially, it is the spinous processes, it is the things that stick out from your vertebrae all the way from C2 to T12. T12 is all of your thoracic area. So let's see. Let's look at origin here. It says it starts at the external occipital protuberance. That is the bump on the back of your head that you can all feel. And then the medial portion, the superior nuchal line of the occiput. That sounds very tricky, but it really just means there's two little lines that come out from that bump. So it doesn't just attach to that bump. It's kind of wide, a couple inches here, and it attaches along that line. Yeah? And then it says it attaches to the ligamentum nuchae, and then it attaches the spinous process C7 through T12. The ligamentum nuchae, what do ligaments do?
Attach bone to bone.
Thank you.
Bone to bone.
Ligamentum nuchae attaches bone to bone. They could have said this in several different ways. Sorry, I'm trying to get some tape going here. They could have said this in several different ways. But the ligamentum nuchae is a ligament that helps you hold your head up. Many mammals have it, actually. And it essentially attaches your skull all the way down to C2, C3, C4, C5, C6, C7. And that's because your head is so heavy that it just helps hold your head up. It can be very thick on some animals, like horses. Do we have any horse lovers here? I know we have horse lovers here. I know some of you own horses. So horses have a massive head that's sticking out in front of them and they have to run. And one of the problems when you have to run with your head forward is your head wants to fall down. Horses have a massive ligamentum nuchae. And it helps to hold their head up. In fact, horses' ligamentum nuchaes are so strong that horses actually, when they go to drink water, have to pull their head down. They actually use the muscles in front of their neck to pull their head down against their ligamentum nuchae to drink the water. Whereas you guys don't have to do that. Yours isn't as strong. But so saying that the trapezius attaches to the ligamentum nuchae is the same thing as saying it attaches to C2 through C7. It's true. It's true. It's more fascia. But what I want you to really remember is this thing hooks to the back of your head and attaches to all the vertebrae. It might attach to those vertebrae via something else. And be prepared for future partner. Yes, bring tape to class. Very good idea. And all the way down to T12. It's essentially attaching to your midline, right? Your spine all the way down. And that's its origin. We already know its insertion. Its insertion is the same as the origin of the deltoid. And it should kind of make sense to you why it might be. If I just do this action, that's just my upper fibers of my trapezius. If I just do this action, that's just my fibers of my deltoid. We don't just usually do this. We usually do this. And that was actually my trapezius and my deltoid moving two joints together to give me this nice fluid action. And that's why they kind of flow together, if that makes sense. Cool? Okay, questions, thoughts? Ms. Everson, please.
I have a pop in my shoulder when I go like above 90 degrees when my trapezius starts working. Is that?
You go above 90. Yeah, you get a pop right in here?
Yes.
In the glenohumeral joint?
Yes.
Okay. Does it hurt?
No, I was just wondering if that's when like the trapezius is starting to activate its muscle is after the deltoid is kind of extended all the way.
It's actually activating before then, but it's when it's activating enough to, you're right, get movement out of that area. You're right. And it means that you've probably gotten to the end of, this is as far as my glenohumeral joint can go out to the side. It actually can't go any higher than this. There might be a few of you that can hyperextend. People think they can go further than this, but what they don't realize is they're actually moving their scapula at this point. See, my finger does not move here because I'm just moving this joint. My finger's going to start to move here. So, yeah, anyway, essentially you're right, ma'am. Yes, ma'am. All right. So that's trapezius and deltoid. Kind of amazing. Kind of cool. Very powerful. Yeah? Yes, Miss Correa.
Okay, so I remember when you were talking about how the trapezius, when it goes up like this, it's the lower fibers trying to keep it from going like all the way forward, right? But the trapezius, when it upwardly rotates the scapula, but why doesn't it also downwardly rotate if it's able to keep the upper parts of the traps from going more forward? It feels like it has more power to pull down, so why doesn't it also downwardly rotate?
Yeah, you would think, right? If the upper fibers upwardly rotate, why wouldn't the downward fibers downwardly rotate, right? Is that what you're asking essentially?
Yeah, only because the lower fibers are keeping the upper from going forward all the way. That's the only reason why I was wondering why it doesn't then also downwardly rotate the scapula.
I don't know. Let me stop sharing this. This is hard to see, but it will explain it. It's not an exact diamond, for one thing. And so it attaches, remember, this is why origin insertions really matter. The lower fibers attach to the spine of the scapula too, which means they come down like this. And we can see that if the top fibers lift, you'll rotate this way, right? We can see that.
Mm-hmm.
Can you see that if I pull on the spine of the scapula here kind of from the side, that'll cause that action too?
Mm-hmm.
If this was way over here, that wouldn't be true. You're right, it would pull down. But it goes along the spine of the scapula and then attaches over here. And so when it pulls, it actually pulls this side down, but pulling this side down lifts that side up. And so it's very weird kinesiology. It's not very weird, it's just more challenging kinesiology. But it actually pulls this side down, which lifts that side up, and we call that an upward rotation. And remember I said all rotations have something going down, something going up. Because of the unique spot about where these fibers go, when you do an upward rotation, your lower fibers and your upper fibers are helping you rotate. Yep. Which means when you guys are doing, go ahead, sorry.
I was just about to say, and because they can only contract, that's why the upper fibers cannot push the scapula down.
Right.
And they also help pull it. Okay.
Yeah, and then they have to help pull it down, not a downward rotation. They help pull it down when it's depression. Yeah.
Mm-hmm. Okay. Thank you.
It's hard. Rotations like that are very hard to see. It's kind of cool. It means that when you're doing a shoulder press, by the way, you're actually using your upper and your lower trapezius, and your deltoids, and a lot of other stuff. But anyway, Miss Hendrickson.
Yeah, I was just wondering about what Ms. Heverson was saying about like the pop in her shoulder. Like, I mean, it sounds like crepitus, like not necessarily bad, but like if the same joint is always popping when you move a certain way, like, is that because of like a cartilage problem or something like that? Because like my knee pops all the time. And,
yeah.
Is there something that you could do to stop that?
I'd like you to entertain this idea. So it's a problem because we've decided it's a problem. She didn't say her shoulder doesn't move properly. She didn't say it hurt.
Mm-hmm.
We just don't think bodies should make noise. We also don't think bodies should smell, right? So we scrub and we shower. And by the way, we should scrub and shower. We're massage therapists and we should be clean. I'm not suggesting we should stop doing this. But as a society, we say these smells aren't good. Your body shouldn't smell. And that's just a normal body doing what it does. I think that's just a normal body doing what it does. They pop and grind a little bit occasionally. And if it doesn't hurt, that's just, we've decided like, oh, it should be like a finely oiled machine. It's not a machine. It's something different. And so I suspect it's just popping over a little tendon that's there or something like that, and whatever.
Yeah.
It could have something to do with how flexible she is in that one joint or whatever, but it's only us that have decided it's a problem.
Yeah.
Yeah. Which I know sounds weird. It's like, but it's popping. Okay.
Right, like it's just like it's alarming, like it
right.
feels like that shouldn't happen.
But if we decided tomorrow that it was cool or sexy, people would be going in for surgery and having little, plastic bubbles put in there so it would pop all the time, right? We'd be like, check this out. Yeah. So it's really just our labeling it. If it's not broken, don't fix it. Yeah. Okay. So by the way, though, the trapezius hooks to the head, right? So the insertion is the shoulders, but I can stop my shoulders from working. I can lock them down. What happens if I lock them down and the upper fibers on just one side contract? Yes, thank you. Thank you, thank you. Cause you to laterally flex. So this is an example, by the way, where the origin is now moving. Because this is the origin here. And it's now moving. So in general, origins don't move and insertions do, but in this case, the insertion locks down, other muscles hold it in place, and we use the upper trapezius to pull the neck over. Now we call this unilateral action. It's not working on both sides. Bilateral action of the trapezius gets me this. Both sides come up. Unilateral, if I lock this shoulder down and just pull this side, unilateral is going to give me this flexion here too. And it's very hard to see. Actually, I think you might be able to see it. Check this out really quick. The other thing is it can also cause rotations in the neck. So if you've got a trapezius here and it contracts, do you see what just happened to the head? No, you don't. It rotates, this is why your book says to the opposite side. This side here causes me to turn and look the other way. So it can unilaterally work to rotate the head to the opposite side of the muscle working. And we know this works because I'm literally doing it with a piece of tape right now. Yeah? This is how it can cause a rotation. And your book makes it very complicated. They say, when it works unilaterally, it rotates the head to the opposite side. And it's just their way of describing rotations. They're saying when this muscle on this side rotates, the head goes that way. If we put this on the other side, head rotates the other way. And that's the trapezius too. There's other muscles that do that, by the way, but that's the trapezius too. Shoot. Is that Miss Clayton? Miss Clayton, sorry. Please.
Yeah. When you're doing that, is it where it inserts? Is that the clavicle part, or no?
Well, on the head.
Yeah, when you're turning your head to the left or right.
This is actually, well, I didn't have it in the right spot, but this is actually your external occipital protuberance and your superior nuchal line right here.
Oh, okay.
And you're right, it does. It goes down into the clavicle here, which gives it really good turning power because it's kind of in front. And so it can pull it to the opposite side quite effectively.
Okay. Okay.
Got it. So it can laterally flex, it can rotate. It all depends on whether both sides are working or not. It depends if the shoulders stay still or not. So the main job of the trapezius is to move your shoulders around, but it can actually move your neck around if your shoulders stay still. So the real big takeaway from all this, by the way, is the shoulders and neck are intimately, speaking about intimacy, intimately linked. Right? You can't have a neck problem without having a shoulder problem, basically. You can't have a shoulder problem without having a neck problem. Like when stuff in here gets messed up, it is the neck is the shoulders. So when you're doing your massage, by the way, don't be afraid to kind of overlap and kind of work out areas because really things aren't just like eat that one part. They always kind of tie into other stuff. Your neck really is your shoulders and your shoulders really are your neck. Now we will talk about them separately so we know where we are in the body, but they're very intimately connected. Cool? All right. Yes, Miss Abelos, please.
There's this condition in pediatric patients. It's like torticollis.
Yep.
And where their neck just stays to the side, and the number one treatment for that is massage therapy.
Yep.
Now, is that the trapezius muscle, or is it all of the muscles in the neck that you focus on?
Yes, it's all the muscles in the neck. Trapezius is one of them. Some people call it wry neck too. It's essentially frozen neck. And it's not like it got frozen in a freezer. What happens is some injury usually occurs and the person doesn't move their neck for a long time, and then all the muscles get kind of shortened and all the fascia kind of builds up in there. And yeah, you have to kind of go in there and strip it out and open it back up again. And it's very soft tissue related, which is why massage is encouraged for that. Yes. Frozen neck, wry neck, torticollis, they're kind of all the same thing. And
have you treated one yet?
oh yeah, many times. It's fun. I love that kind of work.
So it's like how many, is it like 20 minutes or 15 or how long do you spend on a pediatric client in the neck?
Oh, I'm sorry. I have not done a pediatric client.
Oh, okay.
You're talking about a child.
Yes.
Yes. No, I've usually had it in older adults when I've had it.
Really?
Yeah.
Is that from posture or just degenerative?
Posture and like a lot of older. I shouldn't say a lot of older people. Some older people, like when something hurts, they just stop using it. So they're like, yeah, I stopped moving my neck because it hurt when I moved it over. And that problem's long gone, been fixed. But now they're all shortened on this side. And so they come to you and you start opening it back up and getting them to move again. But sorry, no, I've not done it on a child. I've never even seen it on a child. I'm not saying it doesn't exist. I just haven't seen it. But to answer your question really quickly, I'd start with about 15 minutes and see how they react. 2 days later, if they reacted completely fine, I'd be happy to go to 30 minutes. 2 days later, I'd be happy to go to an hour. I just want to make sure that they, respond well and it doesn't over-irritate the area, things like that. Testing the carpet kind of thing. Miss Everson, please.
Do we need like a special license to work on minors in pediatric? Or
Nope.
can we do that?
Nope, you don't need a special license. There are some considerations you might want to consider. Many massage therapists are kind of fearful about being alone in a room with a child. I can understand that fear, and I do think you should take some basic precautions. But I've done it many, many times without incident. Usually when I'm working on a child, the parent is there and they've asked me to work on them, and I've been working on the parent for years and we know what we're doing. And usually the children I was working on, by the way, were athletes. 10-year-old, by the way, athletes that really benefit from massage and things like that. But anyway, no, you're legally allowed to do that. Obviously you want parent consent and all that kind of stuff. And some parents will ask to sit in the room, and I'm all about that. Please feel free to sit in the room. Like however you feel most comfortable, that's fine with me. But if I know the parent well and the child well too, or whatever, I'm fine, whatever they want to do. Yeah. But yes, you too will be able to do that too. All this stuff you can do. Okay. Moving right along. Boom, boom. So, trapezius and the deltoid sometimes work together, sometimes do not. Latissimus dorsi. It's an absolutely beautiful muscle. Largest muscle in the upper body. Essentially hooks into your spine, I want to say from T6. Let's see. Good. Yes, it hooks into your spine from T6, which is halfway down your thoracic vertebrae, halfway down your rib cage, all the way down to your sacrum. Now your book may not put it that way. It might say it inserts into the thoracolumbar fascia, the thoracolumbar aponeurosis, but the thoracolumbar aponeurosis inserts into the sacrum and all those vertebrae. So it's the same difference. This guy hooks into your back from halfway through your rib cage all the way down to your butt. The way they put that is they say it hooks from the spinous processes, the thing sticking out of your back, spinous processes of T6. So you got C1 through C7, T1 through T12. So T6 is right about here. T6 hooks on the last 3 or 4 ribs down here, goes into the thoracolumbar fascia or aponeurosis, and the posterior iliac crest. Posterior iliac crest is the back of your hips. Your iliac crest is your hip bones. These are the back of your hip bones. Posterior iliac crest. It goes all the way down here. And that's really good because if I grab onto somebody there, you can lift them and carry them around without harming them. And in a way, that's what your lats do. Very simply put, if I've got stuff from way down here in my back going up to my arm, don't worry about specifically where, what happens when this contracts? It pulls my arm to my body. Now we've got fancy terms for that. If my arm is out to the side and it pulls my arm into my body, we call that a adduction. If it's in front and it pulls it still down to my body, I didn't hear you, Mr. Singletary.
I thought it was still abduction because you're still pulling it down towards.
Don't
the
say
trunk of the-
abduction, adduction.
I mean, sorry, ADD.
Yeah.
Adduction.
But this is not. This is in this plane.
Flexion?
Well, if it was going up, it'd be flexion. Which one was second?
Extension.
Extension. Even though my arm's in front of me, it's heading where? Back. And this is why, guys, you can do pull-ups like this. That works your lats. You can do pull-ups like this. Forget about what my elbow's doing. This is an extension. This is an adduction. All of it's my lats. Pulling my arms back to my body. Yeah? Does that make sense? Because I'm getting some faces that look like,
It seems like it would be flexion because coming down feels like it would shorten the muscle.
well,
Contract it.
be careful, sir. Everybody does this. Don't get flexing and flexion mixed up. All muscles flex, right? They all contract, and that's what we normally mean. But my joint is performing a extension. Extensions are heading back. They don't have to be in back, they're just heading back. Flexions are heading in front. So, right now, we don't know what I'm doing. Now I'm starting to flex, now I'm starting to extend. Now I'm still extending, now I'm still extending, now I'm flexing. So anyway, this muscle, because it's really long and attaches here, it can pull my arm down like this, an extension, or it can pull my arm down like this, an adduction. It can do one other thing, by the way, because of how it inserts into the humerus, and this is important. It creates a rotation, not the one you'd expect. Usually muscles behind me create lateral rotations because they're behind me and they pull me back like this. This one creates a medial rotation. There's only one way to do that. This muscle comes from behind your back, underneath your armpit, and inserts into the front of your humerus. Into the intertrabecular groove, the groove between the big tubercle and the little tubercle. There's a groove there, the bicipital groove. It inserts there. If I was behind you but reached underneath your shirt like this and grabbed your arms and then pulled, I would immediately rotate you. If I reach underneath your arms here and rotate, I would immediately rotate you. So if you watch bodybuilders trying to pose and flex their back, one of the poses they do is they immediately rotate and flip out their back. And that's why they're doing it. So strangely enough, this thing comes from up your back but grabs onto the front of your arm. So it can actually help to immediately rotate you as well. And those are the only three actions it does. Mr. Singletary, please.
So, like when the bodybuilders, like they're in a competition and they physically turn their back towards the judges and then they kind of flex their arms. Is that what's going on?
Yeah. I mean, you mean when they immediately rotate their glenohumeral joint?
Right. Yes. Yes.
That's what's going on.
Okay.
That's why they're doing it. I mean, they do that pose for other reasons because there's other really big muscles that medially rotate you too, so they can show those off at the same time. But your latissimus dorsi medially rotates your glenohumeral joint.
All right. Thank you.
So we have a muscle that's extremely good at pulling your arms back to the side of your body. Why is this the largest muscle in the upper body? What was God thinking that day? What was she thinking? Why make this one? I mean, it's a beautiful muscle. I like that it's the largest. Ms. Hendrickson, please, you raised your hand first. Why?
I think like for climbing.
Yes, that's exactly right. But why is climbing so difficult?
Probably because it was an important
I like that.
ability for us to escape predators.
Sure, I love that too. Yeah, absolutely. Anybody else want to add to that? It is big for climbing. That's the reason. Mr. Dimitrik, what's so difficult about climbing?
Oh, not about climbing. Is it more to protect those ribs?
Oh yeah, it does, by the way. It does provide protection for the ribs. You're absolutely right. That's a really good point, and I had forgotten it completely, and you couldn't be more right. Mr. Jones.
I would think for back stabilization.
Yeah. Absolutely. What's more difficult to, oh wait, hold on one second. Mr. Craven, please.
Yeah, doesn't it have to like support like a majority of your body weight if you're clapping too?
Thank you. I don't know about you guys, but what's harder to do, a push-up or a pull-up? A pull-up is a hard, kudos to you if you're good at them, but my God, it's a squat for your upper body in the opposite direction. And when I do squats with my lower body, I've got my quads, my hamstrings, my adductors, I've got all these powerful, huge muscles. I've now got to lift up this svelte 230-pound body. I need the largest muscle in my upper body. Climbing is hard. And that's exactly right. You're squatting for your upper body. You're not squatting. But the point is, it's a really difficult task. You need a really massive muscle. In fact, the latissimus dorsi isn't able to do it on its own. It gets the help from other muscles that we're going to learn about later. But that's why the size of it is. It's because climbing is so challenging. Doing a pull-up is so hard. It requires huge, huge muscles. If you think about the other muscles we used to like pick stuff up, like our biceps and stuff like that, really don't even compare. But that's not really what they're for. But to get my arms down the side of my body, which gravity normally does for me, I only use this thing when I'm climbing, it has to be a massive muscle. Absolutely massive. Cool. So, you can read it right off the slide. Let's hear from somebody I haven't heard from. Let's see. I feel like I've heard from a lot of people, though. Mr. Snell, are you there, sir? I know you are. Or you better be. Mr. Snell?
Oh, can you hear me?
Yeah, I can hear you. Hey, Mr. Snell, you can read this right off the slide. What are the 3 actions of the latissimus dorsi?
Extend, adduct, and medial rotate.
Excellent. Mr. Snell, anytime I say latissimus dorsi, I want you to say another muscle. Do you remember what it is?
Terres major.
Yes! Sir, you are rocking it out. What might you guess the actions of the teres major are?
The same. So extend, adduct, and medial rotate.
Thank you, Mr. Snell. Thank you, thank you, thank you. They couldn't be exactly the same, though, could they? But they are exactly the same. It also, by the way, kind of inserts into a very similar location. So, yeah, they are synergists. Thank you, Mr. Jones. Beautifully said, they are synergists. They work together, almost always, as far as we know. But just like latissimus dorsi comes underneath your armpit, your axillary region grabs onto the intertrabecular groove. Right next to that groove is the crest of the lesser tubercle. So they almost insert the exact location, which means they all come underneath the armpit. It also means they are part of what makes your armpit. When you grab onto what we call the posterior border of your axillary region here, 2 of the things you're grabbing onto a lot, by the way, but 2 of the things you're grabbing onto is your latissimus dorsi and your teres major. And they both pull your arm down, down, and medially rotate. That's why anytime I say teres major, you say latissimus dorsi and vice versa. And this guy helps tie your humerus onto your scapula, so it's helpful in a pull-up and things like in a pull-down, all that kind of stuff. And this is why they work together. They help tie the whole scapulothoracic thing together and get your arm back down to the side of your body. And that's it. Yeah, they're both the same. It's beautiful. I love it. It's very easy to find the teres major, by the way, because it is the most inferior muscle on the lateral border of the scapula, which means it's the lowest muscle on the lateral border of the scapula. Mr. Singletary, please.
Where is the, I'm not sure the pronunciation, axillary underneath these guys here?
Your axillary region is your armpit.
Axillary.
Axillary region is your armpit. Truly the same thing. But if you think about it, like they say we live in the valley of the sun, in a way valleys are created because of mountains on both sides. The valley is nothing. The valley is there because of mountains. Your armpit wasn't a pit until you put big muscles on both sides. That's what gave it a depression. Otherwise, it'd just be your arm. So part of what makes the back of your armpit, a big part of what makes the back of your axillary region, is the latissimus dorsi and the teres major. A big part of what makes it in front is your pectoralis major. Anyway, that's why you have a pit, is really because of these two big walls on both sides. Miss Carrillo, please.
Is there a reason the teres major doesn't laterally rotate or downwardly rotate the scapula since it's on the inferior angle of the scapula?
Yes, good point. So why doesn't it roll behind you, right? Is that what you're saying?
Yeah.
So no, I'm not laughing at you or anything. I'm trying to think about how best to explore this. It is behind you. Miss Carrillo's right, by the way, everybody. If I had to just quickly guess, and you told me there was a muscle behind me and it rotates, I'd say it laterally rotates. It's behind me, and if you pull my shoulders from behind, they roll out. So why, Miss Carrillo, is this one rolling in? It's because it sneaks underneath my arm and grabs in front here. So when it contracts, my arm comes in.
I suppose.
So imagine if I was, are you here in the building?
Yeah.
Good. Come see me.
No.
Yeah. Actually, I'm coming to you.
Oh boy. I did it now, guys. Okay, sounds good.
So let us see you. Alright, just make sure the thing, like this is your, go right back there, sit down.
Okay.
Yes.
Yes.
There you go. So, let's get this even more, it's tilted even down a little bit more.
That's as far as it goes.
You're right. So if I,
it's okay.
If I reach underneath you like this, though, and wrap them behind.
Oh, okay. Okay. Oh, thank you. Thank you.
Okay. Sorry, that's just so much easier when you see it. So I come up from behind her, pull her arms from the inside. Miss Abelos, please.
So the lats, they also help you rotate the trunk of the body, right?
No, but I can see why you'd think so. But no, they don't. They're hooked to the trunk of the body. You could argue, by the way, Miss Abelos, they would never write this, but if I grabbed onto something with my arm and it couldn't move, grabbed on a pull here, yes, if I flexed my lats, it would help me it would probably rotate my body in some way. But when we think about trunk rotation, it's usually because the upper body is tied to the lower body and it's pulling me against my lower body, like my abdominals. So I see where you're coming from, but no. Mr. Jones.
Yeah, is it the core or abdominal muscles that rotate your body?
Yeah, mainly it is.
That's what I thought.
You got some other really cute, adorable ones that I really love that we'll learn about. But your powerful rotators of your torso are your obliques, your internal external obliques. That's what rotate your body. Absolutely. They also help you laterally flex, but that's what rotates your body. Yep. Okay. Yes. Oh, sorry. Mr. Richards, sorry.
The lats and the teres major are the same, and they are a synergist. How do they do the same action?
Well, if you and I take our cars, if you and I are both standing if you're standing right next to me here and we both grab on this coffee cup and pull on it, it's going to go roughly in the same place. And so the teres major and latissimus dorsi essentially attach they attach a millimeter apart from each other. They essentially attach in the same spot on the humerus. They come from underneath the axillary region in the same way. They both curve around the front. And they both kind of run down at the same angle. It's true, by the way, latissimus dorsi is infinitely stronger. It's true the latissimus dorsi anchors down to your body and the other one just anchors to your scapula. But they both pull in the same direction, and kinesiology is about pulling in the same direction. So I don't know if that helps you, but that's why. It's because they're essentially coming from kind of the same place and going to the same place, and they're going to both pull in the same direction for that reason.
I think I'm getting confused with antagonist and
Yes, antagonists and synergists. So these guys are helpers. They help each other. Antagonists tend to work against each other. They do the opposite of each other. And these guys can't. These guys, they're either going to help each other or do nothing, but they're usually going to help each other. They are synergists. They are friends. They are helpers. Yeah. Mr. Craven, you raised your hand too, I believe, sir. Maybe I'm wrong.
I did. I don't know if I figured it out or not, but so is the Terres major almost like a fail safe for the lats? Like if you were to get injured or something, like at the very least you'd have some kind of movement just because of that, or like it has nothing to do with that at all?
No, actually, I mean, the reason I'm smiling is we don't know, right? We don't get to ask the person who designed it, so to speak. But what you are saying, once again, brilliantly, is a big theory that I definitely agree with. The body seems to have redundant systems. You know, if you fly a ship into outer space, they don't just have one oxygen scrubber. They don't just have one, thing, because if that thing breaks down, you are screwed. And you're right, your body has overlap. It's got multiple muscles that do the same thing. And you wouldn't be able to climb a tree anymore if something happened to your lats, but at least you'd be able to get your arm back down to your body, right? So we know for that reason. Also, even though I just told Mr. Richards that they're identical and whatever, they're not identical. They're in slightly different positions, and your brain is brilliant. And there might be times I slightly want to pull my arm just a little bit different, and because they're at slightly different angles, my brain could use all these different positioning things to help steer me really carefully. So the redundancy helps with that too, but you're absolutely right. We believe they're backup systems, and you will have clients come to you, by the way, that have paralysis in a particular muscle or whatever, and they're still functioning fairly okay because other muscles can take over. You've usually got at least two muscles that do kind of the same thing at every joint. That's very common. Very common. Yeah. I'm trying to think all over your body, but it's super common. Yeah, so you're dead on right as far as I'm concerned. And everybody, what I'm doing right now, feel free to ask more questions if you have them, but I'm releasing your homework right now. You should see it in just a second. Some of you should already see it. You have 2 assignments. Dun, dun, dun.